So, hello everyone. Today we'll be looking into basically Psych Chantings. Basically, it's a new segment that we have launched so that we can revise whatever we have read. Okay, so it will be a very fast kind of a revision. We won't be teaching something new. If at all, there will be some points that needs to be mentioned. I'll do add on, but yeah, most of the things will be the same. Whatever you have read, we will not disturb it. We'll keep it as it is. So let's start with the very first segment, that is schizophrenia and other psychotic disorder. Now, first of all, always and always, please do remember that we have covered this. Remember that one thing that I would like to ask you is, if I ask you on a very rough note, what is the prevalence of psychotic and mood disorder versus neurosis? Can you give me a rough estimate whether it is less than one or more than one? Come on. For neurosis, is it more than one or less than one? So yes, remember that for neurosis, it is more than one. Always and always remember this. For neurosis, it is more than one, be it depression or be it, on a very rough note, that anxiety part. What about this? Bipolar, OCD, and schizophrenia. Is it less than one? Yes, less than one. Very good. Now, if you know this, it is very much clear that you'll be able to write that percentage in a very, in a very clean and a very exact manner. See, this is what we are talking about. Okay, this is what we are talking about. This. So remember that bipolar scales OCD. Bipolar scales OCD less than one, less than one. It is less than one. And the other part, that is the neurosis one, it is more than one. It is more than one. Okay. Do remember that this is according to what we have read in National Mental Health Survey 2016. Remember, the current ongoing survey is there, but still we don't have the data. One more thing, one more thing. Please do remember regarding global epidemiology, it is just the same. Look, it is just the same. Point 3 is also over here. Okay, so I hope these percentage you won't be missing. Now, just a kind of a overlap. Any mental disorder that was 10.6%, here it is 13%. So it's again the same. And here also you can see anxiety, depression, it is more than one, more than one. 3 to 4%, 3 to 4%, roughly what is there in NM, National Mental Health Survey. Okay, now, if you know this, next we'll go for the definition. Now, see, in the definition, I'll just ask you one thing, that what is the difference between psychotic symptoms and positive symptoms? What constitutes psychotic symptoms? Come on, be fast. Two things that makes up psychotic symptoms. You can use the abbreviations also. Very good. Delusion and hallucination is psychotic symptoms. What is positive symptoms? Psychotic symptoms is delusion and hallucination. What is positive symptoms? Positive symptoms. What constitutes positive symptoms? Yes, very good, Shakil. Very good, very good, very good. Disorganization, abnormal behavior, very good. So, psychotic symptom, it is only delusion and hallucination. Positive symptoms will consist of delusion and hallucination, plus there will be abnormal behavior. And as I have mentioned, abnormal behavior, speech, disorganization, all of this will come under a broad heading, that is positive symptom. So, all of you know this, that this is what is mentioned for ICD 10, what is meant by the term psychosis, delusion, hallucination, and limited number of severe abnormality. It is not psychotic symptom. Remember, it is not psychotic symptom. It is psychosis. So remember that there is a difference between psychosis and psychotic symptom. Psychosis, you have to write this part, that delusion and hallucination is there, but apart from that, we have severe abnormalities of behavior. Now, one word that I would like all of you to remember is amylcreplin. Now, just let me know, what do you know about amylcreplin? What is the dichotomy? What are the two things under dichotomy? Come on. Yes, manic depressive psychosis and dementia precox. Very good. Dementia precox, manic depressive psychosis. Apart from that, do you need to know something else regarding amylcreplin? Regarding amylcreplin, do you need to know something else? We have already read this. Yes, very good. Remember this part. Organic psychosis. He was able to separate organic psychosis from a broad spectrum group of psychosis. So that is the very first line that you'll be writing. And the second part, all of you have mentioned, is dichotomy. Okay, so remember this, for amylcreplin, you are not going to make mistake in two things. Firstly, the wordings. Please, please, please focus on this. It's crepelin. It's not creplin. We speak creplin, but we write crepelin. So don't miss the two E. Don't miss the 2E. And remember, there are two things. One is organic psychosis, delineated from a broad group. And second is what you have mentioned, the dichotomy part. Now, next person that we'll be looking is Eugene Bloiler. Eugene Bloiler, come on. Bloiler 4A. 4A. Remember that 4A. If I ask you, is it only autistic behavior or it is something more? Autistic behavior and thinking. So ABT is there. Now, what is the hallmark of illness? According to him, he has mentioned some hallmark of illness. What is that hallmark of illness? Come on. Focus on this line. Yes, yes. There is a lack of harmony between TEB, thought, emotion, and behavior. Now, one more thing. According to him, what is the most obvious feature? What is the most obvious feature? It is not SFRS. It is not something hallucination, delusion. What is the most obvious feature is accessory symptoms. Means apart from all of these things, there should be something more. And these are accessory symptoms, which was mentioned by Eugene Bloyer as the most obvious feature. Remember, it is not your similar kind of a thing which you are reading in MBBS or in your NEET PG or INI CET preparation. It is very different from that. We have taken from CTP and remember them in the same manner. Okay. His son, Manfred Bloiler, what was the area of study? Area of study of Manfred Bloiler? Come on. No, area of study is so the place where he carried out his studies was Java, definitely area of study where what was the disorder in which he was looking for? Yes, epidemiological data he has received. What was the disorder on which he carried out his study? Yes, remember, just like his father, he was also looking for psychosis. Very, very, very important. Now, Kurt Snyder, remember Snyder. SFRS is not pathognomic. SFRS are not hallmark of illness. Now, just let me know the three thought phenomenon. What are those three thought phenomenon included in this? Come on. Thought phenomenon. Yes. No, 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 no. Thought phenomenon is yes. Thought withdrawal, thought broadcast, thought insertion. These are the three thought phenomenon. Now, look after this. Don't get confused with auditory hallucinations part. And what are the three component of auditory hallucination? If I roughly say that, what are those three things? All of you are correct regarding thought phenomenon. So one is audible thoughts, voices arguing or discussing, and the next part is audible. Yes, yes, all of you are correct. No, one, two, third person, please, please, please don't make it wrong. It's not your MBBS. Again, I'm saying these are the words that you need to mention. Don't mention first person, second person, third person. It's a sin to say this when you are a MD psychiatry resident. Don't say that. Please mention audible thoughts, voices arguing or discussing, and voices commenting on person's action. See, what you are reading in MD, it is a very refined version. Don't get into the trap of oversimplifying it. Some part of psychopathology you have to speak in the same way as it has been written. You can't change it. Okay, now one more thing regarding, is there any difference between delusion of control or made phenomenon, or is it just the same? Come on. Is it same or different? Same, same, same. Yes. Only thing is that the wordings are different because they have been classified in PSC and SFRS. Made phenomenon is the term which we will be using in SFRS, and delusion of control is the term that we'll be using in PSC. So remember, the names are different. It means the same. It means the same. So remember this. If delusion of control is there, it is to be mentioned at delusion part. Okay. In PSC, because of oversimplification, that is where the conversion goes on. Now, coming to DSM-5, schizophrenia, what is the time frame for which you will measure the symptoms? Come on. 6 months, 6 months, 6 months. 1 month is for acute phase, one or more than 1 month. Always say 6 months. Always say 6 months. Very good. Yeah, for acute, you can say one or more than 1 month, but again, you have to mention the 6 months. What are the two things that you have to look for, or what are the five features? Okay, two out of five is required. What are the five feature? Delusion, hallucination, disorganized speech, catatonic behavior, and negative symptoms. Remember, negative symptoms is there. You need to mention it. Yeah, very good, Rohil. Very good. Nice, Hasmukh. Fine. Now, I just want to ask you one important part. Why this is not required? Snyder first rank symptom, why it has been dropped from ICD 11, the new one. There were three reasons that we have discussed. Come on. Yes, longitudinal stability is not established per se. Anything else? You are very correct in this. Yes, not pathological. Yes, no treatment effect. Basically, there is no impact on the treatment. Number two, the longitudinal stability at stake is at stake, and per se it is not pathognomic and it doesn't help in anything. Yeah. So, if you have to write about psychosis, whatever is being mentioned till now, from epidemiology to your definition of psychosis to your classification of psychosis, and some of the historical snippets that will include your Bloiler, Schneider, okay, and remember about Kreplin also. So these are the introductory part that you can write also. Okay, don't feel that, you know, like what I have to write. Just write it in this flow also. You'll be able to make up for that amount of content that is required. So don't worry about these things. You all are doing good. Next, if you have to look into this type 1, type 1, type 2, who has given this type 1, type 2? Batao, who has given this? Yes, Timothy John Crow. Full name, please. TJ Crow is like DJ. So don't go for that. Now, what were the three studies? What were the three studies? Batao, what were the three studies? Mention it. Come on. One was CT based. Second was, second was, second was drug. Very good. What was the third? And the third was the PM finding, that is the post-mortem finding. It's see, MRI came quite late. Okay. So don't mention regarding MRI. It is CT, drug, and your post-mortem finding. Now, if you are mentioning CT, drug, post-mortem finding, name the drug. Come on, name the drug. Flupentixol. Very good. Now, which are like which among the two is having a better outcome? Type 1, type 2? Always and always type 1. Just we'll go through it quickly. That type 1, if you look into all the three studies, basically we did a CT scan and we found out that there is something which is called as enlarged ventricle size in patients with schizophrenia. They are more commonly associated with negative symptoms. Okay, and remember this part, that yes, flupentixol was able to show effect in positive more as compared to negative. Negative per se doesn't have any effect. And post-mortem study, we were able to find that D2 receptors was related to positive symptoms and not with negative symptoms. Three important points pertaining to positive and negative things. Okay, and remember that type 1 is having a better outcome as compared to type 2. So you have to write this thing if they ask regarding type 1, type 2. Next is Liddle syndrome. What about Liddle syndrome? Name the three things, three important syndromes under Liddle syndrome. Remember, you can remember it through positive, negative, cognitive. Very good. One is disorganization. Nice. Disorganization. One is psychomotor poverty and reality testing. Okay. As you have mentioned, reality testing, what will be there in reality testing? Think about it. There are three syndromes that are coming under a broad heading of Liddle syndrome. Remember, all of you are correct. Reality distortion means the person is not in touch with reality. It's a very generic way of saying that the person is having delusion and hallucination. Delusion and hallucination is present. Now remember that this part is done. Next, if you look into psychomotor retardation or psychomotor poverty syndrome, means you will have mostly the negative symptoms, poverty of speech, flatness of affect, and what is meant by decreased movement. So psychomotor poverty, speech, very good. Speech, affect, movement, very nice. And then the last one is disorganization symptoms, in which you will have disorganization thought and also affect. Now, here also remember this, that reality distortion means basal ganglia, hippocampus, increased activity. Now, disorganization, remember this part, disorganization is associated with DM thalamic nucleus and anterior cingulate cortex and ventral prefrontal cortex. Just giving you an like a overview connection. Ventromedial prefrontal cortex is associated with your mood and per se your communication part. Yes, these set of patients who are having disorganization syndrome, they are having mostly something related to negative part or the negative symptom. That is why these set of areas will be affected. If per se we look into psychomotor poverty, this is where it is associated with executive function. So executive function is being taken care by, yes, left dorsal prefrontal cortex. Now Neurodevelopmental classification. What comes under neurodevelopmental classification and who has given it? There are three subgroups that comes under it also. Remember this. Robin Murray, very good. Robin Murray, one is congenital, one is adult, one is very late onset. Very good. So three for two for type 1, type 2, three for Liddell, three for neurodevelopmental classification. Nice. So it was given by Robin Murray. And congenital schizophrenia, which is neurodevelopmental. We also have adult onset. And last one is very late onset schizophrenia, which is degenerative schizophrenia. Or what we call it as we have this explanation that because of the degeneration that is happening, the person develops these set of symptoms. Now, which out of them will be having the most poor outcome? Congenital, adult, very late onset. So it's congenital. Remember, earlier the onset, poorer the result. Now, coming to this, I would just ask you two important things. What is the prominent symptoms that you'll be able to see in congenital schizophrenia? Is it positive symptoms or more of negative symptoms? More of negative symptoms. Very good. And one of the important core pathogenetic uh, phenomenon which happens in this is, what is the reason that happens? Yes. No, no, no. Minor physical anomalies and neurological soft sign you'll be able to find in these set of children. Nice. Abnormal cellular migration. Please remember this. This has to be mentioned. This has to be mentioned. You cannot miss on this. Because of abnormal cellular migration, proper development of brain area is not happening. Hence, what is there is a formation of a brain network that is pretty much in a haywire form. It's not well compacted. It is not according to what is required for a network. Next, coming to this adult onset, always remember female more than male, more positive as compared to negative, and affective component will be present. Affective component is present in adult onset schizophrenia according to this neurodevelopmental theory. According to this neurodevelopmental theory. Okay. Now, deficit syndrome, time duration for for diagnosis of deficit syndrome. Yes, 12 months, 1 year, 1 year, very good. And who has given it? Name the person. They are Strauss and Carpenter. Strauss and Carpenter. So Strauss and Carpenter has given this deficit syndrome. You can write it over here as an individual note that can come. It can also come in form of something like we call it as negative symptom. In negative symptom also you'll get deficit syndrome. And please, please, please remember this. I'm saying so much, please. You have to please read DDDC. Okay, so D3C. Please read DC Comics, and you need again two or more than two negative symptoms. Now, just a kind of a kind of a common connection. What is the minimum symptom that you require to qualify a diagnosis of schizophrenia according to DSM-5? Two. What is the time duration? I haven't asked. I asked number of symptoms. Two. What is the minimum number of symptoms that you require to classify a person as schizophrenia according to ICD-11? Okay. Answer, answer, come on, answer. ICD-11. DSM-5 it is 2. ICD-11 it is. So out of, very good. If it is present A to D, you can get 1. In total, you require 2, isn't it? You require 2. Mostly you require 2. Same thing will be also applicable for here also. You can see more than equal to 2. Okay, more than equal to 2. And you can remember it like please read. So basically it is just a negative symptom classified by Strauss and Carpenter: poverty of speech, restricted affect, decreased emotion, drive, purpose, curbing of interest. That is anhedonia. Okay, now all of you have gone through it. So I'm really happy. Remember one thing, in ICD-11, they do give emphasis to cognitive symptoms. But is functionality criteria included in ICD-11? Remember? No, it is not included. Not included. Remember this part, please. And one more thing, all of you have answered this part, so I won't be going again. Now, please remember course specifier. Course specifier is important. So we have course specifier for first episode, multiple episode and continuous. First, multiple, continuous. First, multiple, continuous. And remember this part. If you are not able to recall what is there in ICD 10, don't worry. Please remember this for ICD 11. First episode, symptomatic. First episode, partial remission. First episode, full remission. First episode, unspecified. Similarly, multiple episode, currently symptomatic. Full remission, partial remission, unspecified. Continuous, currently symptomatic, partial remission, full remission, unspecified. So first, multiple, continuous, and then you have the remissions. Okay. Partial, full, or symptomatic. I hope it is easy. Core specifiers. Come on, come on. Okay. First, multiple, continuous, symptomatic, partial, full. Symptomatic, partial, full. Come on. Think about it. Now, another important part, ATPD. Earlier we had how many disorders under this rubric? ATPD. How many disorders were there under this rubric? 4. Very good. 4. Now, according to ICD 11, what is the change? What is the change? How many disorder is there under this rubric? According to ICD 11, what is the number of disorder under this rubric? ATPD. Only one. Remember, very good. All of you are really interested, and I'm really happy that you are all answering. So earlier we used to have 4. Now it is one. Only one. Where it is? See, acute polymorphic psychotic disorder without symptoms of schizophrenia is what is there in ICD 11. Rest all 3, they have been placed somewhere else. Number 1, this has been placed under delusional disorder, which was earlier a part of ATPD, and other primary psychotic disorder. These 2 things have been placed over there. Now, see, de-emphasis, all of you have covered. Nice. This is what we have been talking about. Out of these A, B, C, D, you need to have at least one. But if suppose you have 2 out of A, B, C, D, that is also okay. But if you have one from A to D, you need one from these next lot. So core criteria, and then you have other set of 3 symptoms. Now, coming to this, all of you have known, okay, we have covered this. Now, these are the 6 domains under which we cover our psychotic disorder. Please remember positive, negative, depressive mood, manic mood, cognitive, and psychomotor. Okay, so these are the 6 domains under which we cover our psychosis. Okay, now, very good. Okay, we have covered this part. We have covered this part, and I'm really happy that you have remembered this. Okay, now minor physical anomalies, just mention 4 minor physical anomalies that you can easily remember. What do you know? I'll just tell you what are those 4, but I'll ask you to write down 4 important physical anomalies. Look into the face, hair, hand, and foot. Come on, name 4 minor physical anomaly. Very good, very good. Ear, what is ear? We have low set ears. Think about it. Low set ear, very common thing. Low set ear means, see, my ear, if you look like this, if you draw a line connecting the outer part of my ear, which is the outer canthus, to tragus, you can see that above this line, you'll be able to see that my ear crosses this line. This is what is meant by this. See, if you draw this line, you can see that, sorry, if this is the tragus, you can see a portion of your ear will come above the line. But if it is low set ears, it will be like this. Nothing will come. Yes, coarse hair, low set ear, saddle toe, clinodactyly. Remember that these might be minor physical anomalies, and these are very prominent in which set of neurodevelopmental, or is it congenital, or is it neurodegenerative? Come on, think about it. Where it is more commonly found? It is found in congenital schizophrenia, according to the theory that we have read, which was given by Robin Murray. Very nice. Now, coming to the neurobiology, all of you have known this part that we do cover neurobiology according to, first of all, neuroanatomy, neurochemistry. Then we'll be looking into the circuits and the other concepts. Number 1 is this. What is the region that we are looking for? The region that we are looking for is this cortex. Next is subcortical region. Remember this cortex and subcortical region. These are the two areas where we are looking for. And in the subcortex, we are looking at basal ganglia. We are looking at basal ganglia. Okay. And in the cortex, we are looking at prefrontal cortex, and temporal cortex. Please, please, please remember this. Very good that all of you are mentioning temporal cortex, prefrontal cortex, and striatum. Okay. So if you remember this, it's easy for you. Now, there is a switch in all of these. Dopamine and glutamate is increased in the subcortical region, whereas it is decreased in the cortical region. Okay. Cortical region and subcortical region. Now, I would again ask you to please draw this in your exam. Make a kind of a diagram, brain in between, and then you draw this kind of a chart so that it will be clear to the examiner that you know all of these concepts and you're trying to incorporate them in your answer. Okay, right before you answer neurobiology, please draw this. Okay, and next, okay, mesocortical pathway associated with which set of symptoms? Come on, be fast. Mesocortical pathway, mesolimbic pathway, very good. Mesolimbic positive. Nigrostriatal pathway. Yes, and that is the side effects. And the very good. Movement, EPS, prolactin. Okay, hyperprolactinemia is one of the component. So remember this mesocortical. Means midbrain. And from here you will have connection. So mesocortical is this going to the cortex. Mesolimbic is from the midbrain, you will go to the limbic system. Nigrostriatal is this part, and then you have this tubuloinfundibular. Remember this important four. Now, so you have covered the neuroanatomical regions. You have looked into the common set of, okay, the circuits which are involved. But let's look into the neurochemistry. Okay, dopamine. Dopamine is increased in basal ganglia, that is the striatum, or it is reduced. It increased. What about the dopaminergic system in the cortex? It is reduced or increased? It is decreased. Coming to the glutamate dysfunction, is it is happening. Per se, you don't need to add any evidence in or against. You need to write everything according to the flow. Okay. Don't have to give any kind of an evidence like for this, we have this kind of evidence as of now. If they ask specifically writing about the evidence, then you need to mention it. Otherwise, you have to mention the whole thing. You don't have to look for whether you have covered this part or not. Okay. Now, coming to glutamate, all of you know it is having a dysfunction at glutamate. Now, glutamate dysfunction is happening secondary to which neurotransmitter? Yes, parvalbumin positive GABA interneuron dysfunction. This is the key things to remember. This is the key thing to remember, that this is the damage which is happening, because of which it leads to glutamate hypo or hyper. Hypo or hyper. What will happen if this? Yes, it is hyper. Hyper excitability is there. That is why it causes neuronal damage. Okay. Why? It impairs cortical inhibition, leading to hyperactivity. Gamma oscillation defect is there, and this leads to cognitive and negative symptoms. GABA, all of you are knowing this. So nice. Role of acetylcholine is also there, involved in attention and concentration, processing speed. Now, all of you are, so please, this is the summary of neurological networks. These are the things that are important with your neurochemistry part. Okay, already we have covered this, how this GABA interneuron is important. GABA interneuron inhibit glutamate so that they don't fire, in a large number. They keep it under a particular, see, if glutamate is required to fire 10 units, and if it is not under the control of GABA, it will fire 100 units. So basically, GABA is keeping a check on glutamate neurotransmission. If that check is being removed, it will overfire, and ultimately it will lead to the symptoms which is prominent in cognitive and negative domain. Okay. Now, This is the detailed part. We have already covered this. Okay. In neuroimaging finding, you have to mention regarding decrease in volume of the brain, enlarged ventricle, and gray matter reduction in whatever area that you have mentioned. Specifically, these six areas you have to mention. Now, DW MRI, yes, there is problem associated with frontotemporal tract. These are the white matter tract which is associated from frontal lobe to temporal lobe. So these are the important three tracts that you have to mention that yes, there is problem in these white matter tract. Next, corpus callosum is also not functioning properly. Corpus callosum is also not functioning properly. Okay. And MR spectroscopy, you need to know that glutamate to glutamine, there is increase in ratio. On treatment, it reverses back. Now, coming to the postmortem findings, yes, decrease in dendritic spine density in layer number 3, decrease in neuropil, decrease in interneuron marker, and subtle hippocampal alterations is also noted. Now, this evidence that we have written over here, you don't have to write them. I just provided this evidence so that you can have a reference to whatever we are writing. It's not something that I write one line and you have to take it just because the reference is trust me, bro. That is not how it happens. You cannot trust anyone. If I say that whatever I am teaching and whatever we are reading, if I say this is the what is the reference? Just because I'm saying, trust me, everything is fine. No, that doesn't work in psychiatry or in any branch of medicine. Okay. So why I have provided this? So yeah, so that if you have any doubt, if you want to read in detail, you can go and search them and you'll be able to find that whatever we have written, we have collected the evidence from the past 5 years. Okay, most of these things are not yet mentioned in books, but you have to write this. Okay, I hope I'm clear to everyone. Okay, fine. Now, so जो भी चीज हमने पढ़ा, they have all been included. Don't have to go here and there. Next. Okay, all of you know this part. I'm not going deep into this. Coming to genetics, I'll cover only three things that you need to know. First of all, remember this Ernst Rudin, family history of schizophrenia, and Irving Gottesman, two thing. So 2T, two, so basically twin studies. Ernst Rudin is family study of schizophrenia, which is the chromosome that is highlighted in Manhattan plot. It is chromosome number 6. Remember this, chromosome number 6. Fine. Now, next, looking into this part, remember one more thing. Whether in twin studies, what was the finding? Whether it was 100% concordance or there was some, it was less than 100% concordance. What was the finding? It was less than 100%, 64. Very good. So if you don't remember the number, at least you can say it was less than 100% concordance. Okay. Remember that concordance, if it is 100%, it means it is purely genetic basis of disorder. Okay. And if it is less than 100%, what does it mean? Come on. So some part of is there apart from the genetic component. That is what is meant by if there is less than 100%. Okay. Now, so we have discussed this in detail. It was just a kind of an overview. Now, coming to this, remember that neurotransmitter genes, important neurotransmitter like dopamine, glutamate, okay, all of these synaptic release of neurotransmitter gene, like for example, calcium signaling gene. So all of these genes are mentioned in genome-wide association studies, and you have to remember them. If you even if you don't remember these names, no, at least you have to write this that dopamine receptor D2 gene, glutamate neurotransmission and synaptic plasticity gene, calcium signaling gene. At least write these things. If you don't remember this, I'm just saying that the bare minimum is you need to mention these three things. If you are able to mention these part also, no, that's also fine. Next, coming to copy number variant, you need to know regarding neurexin. Okay, what is neurexin? Think about it. What is neurexin? Yes, it is associated with serialization. Just a minute. Yes, it is a cell adhesion molecule which is associated in increased risk of development of schizophrenia. Remember this, specific to the synapses of the brain. So it is a brain specific molecule which is there in synapse, and remember it is associated with cell adhesion. So NRXN1. These are the genes that you have to remember: DISC1 and 2, DTNBP1, NRG, RGS4. If you are not able to write the short forms, go with these things. Remember the zinc finger that we have mentioned. In short, this is what we have read for genetics. That is, synaptic genes are implicated, cell adhesion genes are mentioned, downstep regulation GPCR genes are also implicated. And this is the summary. If you are not able to write whatever we have discussed in detail, at least you can write this, that the family study says that you have 10% or more chance to develop schizophrenia according to the familial studies and factors. Twin studies, heritability is like this. 64% is concordance. Adoption studies have also shown that risk is similar to what mentioned for familial transmission in adoption studies. And these are the important genes which are mentioned. So if you're not able to write the whole thing, at least this page is sufficient for writing under the heading of genetics of schizophrenia. This you have already done. 5 important categories of negative symptoms, just mention it. What are they? Come on, mention regarding these things. 5 important domains. Look at them. They are just, yes. Use the abbreviation form. You don't have to write the whole thing. AB, affective blunting, elogia, evolution, anhedonia, asociality. Yeah, that is good. Great. Now, according to matrices, it is being said that you have to mention these 5. No deficit symptoms or a syndrome kind of a thing has been mentioned. Remember, these 5 things are important. Yeah. Next. Hmm. There is a correlation between negative symptoms and cognition. Remember this part, that negative symptom and cognition, it is positively correlated. Negative symptoms with disorganization symptom, it is also correlated. So please do keep a check on these 2 important lines that are there directly from CTP. Okay. There is a very poor correlation between disorganization symptoms and negative symptom, but it is associated. So please remember this. Cognition, it is having a very good association. Okay, what about association between positives? Okay, by the way, which among these symptoms are more heritable? Negative symptoms are more heritable or positive symptoms are more heritable? Yes, heritable, negative symptom. Negative symptoms are more heritable as compared to positive symptoms. And after negative symptom, which are those set of symptoms which are like you can see that disorganization symptom is also more heritable. Okay, remember this. Next. Okay, now you know this. Okay, what are the secondary negative symptoms? Remember treatment, seconding, like all those negative symptoms developing secondary to the treatment. Okay, dementia, PTSD, OCD, depression, anxiety, insomnia. So remember these parts. If you have to remember, at least remember 5 things: treatment, medical comorbidity, substance, and remember these comorbid things: depression, anxiety, OCD, PTSD. If possible, try to make this wheel chart. Next, okay, treatment of negative symptoms. These are the important molecules which actually help in treatment of negative symptoms. Okay, so remember the antipsychotics: amisulpride, cariprazine, aripiprazole, clozapine, roluperidone. Roluperidone is an upcoming thing, but the evidence says that it is having some kind of benefit. Just focus on what we are discussing. Okay, you'll be able to grasp a lot. Once we are done with this session, you'll be able to remember a lot. Antidepressants, yes, you can add SSRI, SNRI if there is a negative, sorry, if there is a depressive symptom which is prominent. Somatic treatment. This is intermittent theta burst stimulation in left DLPFC, and TDCS is having plus minus kind of a thing. Remember that N-acetylcysteine 1200 to 3600 milligram per day. And psychoeducation, this is CBT for negative symptom and rehabilitative measure. These are the 3 rehabilitative measure. No role of ECT For negative symptom, these are the domains in which you'll write the answer. If they ask what are the important treatment modalities for negative symptoms, then you have to write all of these: antipsychotic, antidepressant, somatic, others, psychotherapy, and then we have to mention the rehabilitative measures. Now, cognitive symptom, all of you know this. All of you know this. Great. Coming to this part, what are the important domains? So, treatment of cognitive symptom. So, you have psychological and digital treatment. Okay. Specifically, what is this? CR? Come on, be fast. Yes, cognitive remediation. And what is the CET? Cognitive enhancement. Yes. Remember, these two notes have been provided when you go through community psychiatry. At the end, you have the comparison chart between CR and CET. Okay. Next, physical exercise, small to moderate benefit. RTMS has shown some benefit, specifically DLPFC region when we apply ITBS, intermittent theta burst stimulation. Mixed results with TDCS, stacks. Pharmacological agent, no approved agent. Eclapertin, remember, an add-on thing is there. Phase 3 trials have shown negative results, as a result of which the company Boehringer Ingelheim, they have stopped the trial for this molecule, eclapertin, for treatment of cognitive symptoms. So for treatment of cognitive symptoms, they were developing eclapertin, but now because of the results that it is negative, that it is not able to meet the endpoints, they have stopped the trial. So eclapertin is an old thing now. It has happened in this year only, but eclapertin is no more being developed for treatment of cognitive symptoms in schizophrenia. Cobenfy, again, negative result is there, but post hoc analysis has shown plus and minus kind of a result. These are the adjunct molecule that you can use. Again, you will see that N-acetylcysteine, cholinesterase inhibitor, modafinil, roflumilast, okay, glutaminergic modulators, memantine, you can add. Do remember regarding these points. And medication hygiene, you have to remember this. So for treatment of negative symptom, treatment of cognitive symptom, you have to read something more than what is mentioned in the guidelines. Now, assessment, all of you know, these are the minimum, bare minimum tests that you have to do. Okay, now coming to the management. According to Maudsley, what is the duration after which we'll be changing the antipsychotic? What is the duration? Yes, it is 2 to 3 weeks. Now, 2 to 3 weeks, come on. What is 12? There's nothing called as 12. Yes, 2 to 3 weeks. Okay, so if I have given a trial of 2 to 3 weeks, first antipsychotic, if I am the patient, and if you are not able to find any benefit, what will you do? Suppose you have started, yes, second antipsychotic, what is the duration of trial? Second trial you'll do change. Again, it is 2 to 3 weeks. And if at all with the second antipsychotic also, you are not able to perceive any benefit in me. So I'm a patient, I'm coming to you and you're not able to do what you'll do. You'll switch to clozapine. Now, just let me know what is the choice of antipsychotic that you're going to give me on my first trial and second trial. Is it SGA or FGA according to Maudsley? So it's only SGA. You don't have to use FGA in this scenario for management of schizophrenia according to Maudsley. Now, if someone asks me what are the agents that you will be using or is preferred by Maudsley, what is those set of agents? Those which are having long-acting injectable formulation. Yes. So it is risperidone, olanzapine, aripiprazole, paliperidone. All of these are available. Remember, they do have long-acting formulation. That is why they are preferred. Okay. So 4 to 6 duration total, and then 2 to 3 weeks trial that you have to give. Now, next is, suppose I am maintaining well, and then what happened that I have been able to be in the follow-up also. Adherence is full, still there is a relapse or acute exacerbation. What are you going to do? Reassess, give benzodiazepine, very nice, and switch to a different or a more acceptable antipsychotic if appropriate. And then you have to assess over how many weeks? 6 to 8 weeks, 6 to 8 weeks. Very good, 6 to 8 weeks. If I am coming to you, okay, and there is a relapse or exacerbation, but remember that adherence has not been defined. You cannot make sure whether I was taking the medication regularly or not. In that scenario, what are you going to do? This scenario was when there was full adherence, full adherence. There was one thing that you have to do when there is no information available for adherence. This is the next thing. If there is poor adherence, what you are going to do? You will look for, okay, we can give a simplified regimen, you can decrease anticholinergic load, you can consider compliance aid and consider depot. Lack of insight, you can consider depot. Poorly tolerated medication, you will switch to an antipsychotic or give LAI. Remember one thing, if adherence is doubtful or not known, the last resort or common thing among all of the modalities that has been mentioned is one thing that you'll have to use LAI. Poor adherence, remember LAI is one thing. So, according to Maudsley, first episode, you are done. 2 to 3 weeks, 2 to 3 weeks, clozapine, done. Next, full adherence has been established. Still, you will assess for 6 to 8 weeks, give benzodiazepine, change the drug if required. But if patient is not able to respond, you will switch to clozapine. Okay. And when adherence is doubtful, you can just assess everything and you'll go to the end resort, that is LAI. Okay. Now, coming to this part, what is the duration of treatment of first episode according to NICE guideline? According to NICE guideline, first episode psychosis according to NICE guideline. अरे देखो यहाँ पे लिखा हुआ है द ड्यूरेशन ऑफ एंटीसाइकोटिक ट्रीटमेंट फॉर फर्स्ट एपिसोड इज नॉट क्लियरली डिफाइंड बाय नाइस गाइडलाइन. Coffee pio, have something, and then sit. Okay. Now, according to Ranzap, 2 to 5 years. Okay. And what is the recent addition in 2026 IPS CPG guideline? What is the treatment duration that you'll give for a patient who is coming with first episode psychosis? 1 to 2 year, 1 to 2 year, 1 to 2 year. Yes, 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 yes. 1 to 2 year. Write it down like that. 1 to 2 year. First episode psychosis, 1 to 2 year. Okay. This already you have covered. We have covered this. Note on ECT, whether ECT is beneficial for treatment of psychosis, yes or no? In which scenario it is helpful? In which scenario it is helpful? If you are saying yes, where it is helpful? Yes, when you are augmenting clozapine. Very good. Very good. Okay, when you are augmenting clozapine. Very nice. So use of ECT for augmentation in case of TRS. All of you are answering well. Now, next part is this. You know this part. You don't have to go in detail. Remember the pointers in which you have to look for various set of factors and then you'll choose a particular agent. Acute, continuous or continuation or maintenance phase. Remember the number of goals. 6 goals are given in acute phase. Continuation phase, again, you have to monitor for response, side effect, treatment adherence. Okay, some of the questions that I got was regarding the time duration. Per se, you cannot form a time duration for acute management, continuous management, and this maintenance because each patient is different. That is why you cannot give a very strict timeline. That strict timeline is given in depression, not in this. Now, how to proceed? All of you know. Here, what is the time duration for giving antipsychotic? According to CPG IPS guideline, what is the time duration? It is 6 weeks. So suppose if I'm a patient coming to you, you are going to give me first antipsychotic 6 weeks. And the second antipsychotic, what will be the duration? Again, it will be 6 weeks. Now just let me know whether you can use SGA or FGA. Which among these two you'll be using? You can use both. You can use both. SGA, you'll be using it, but you can use both of them. Okay, remember that in the old guideline, they do mention regarding antipsychotic, one of which is SGA. In the recent one, they are also mentioning that you can use SGA, but you can use FGA also if that is something which the patient is able to tolerate. So we have not still get rid of FGA. FGA is still present. So if you have given me one trial, 6 weeks gone, I'm not able to perceive any benefit. Second trial, 6 weeks gone. And then after how many weeks in total from the initiation of treatment, you'll be giving me clozapine? So 12 weeks. Very good. Very good. And that brings us to the next thing. Okay, already you have covered this. Coming to TRS. TRS, think about three criterias. What is the minimum treatment duration that you will be looking for? Come on, let's revise TRS Keynes criteria. 5 years. Okay. How many treatment? How many treatment? How many times the treatment? Three times, at least two different classes. And what is the drug equivalent of chlorpromazine? Drug equivalent of 1000 milligram. Very good. And what if this is the historical aspect? This is the historical aspect. 1000 milligrams of chlorpromazine equivalent for a period of 6 weeks, and there is no relief. Coming to the actual, now see if the patient is right sitting in front of you, and then you have to look for whether it is fulfilling the criteria of TRS or not. What will be the set of items that you will be focusing on BPRS? CUSH. Yes, CUSH and CUSH. The score should be how much? More than equal to 4. More than equal to 4. So in any of these four, out of these four, if you get two also where they are having the score more than equal to 4, and the total BPRS score should be more than 45. Along with this, CGI is more than equal to 4. Then it is a case of TRS. Now, suppose you want to give the treatment and then you want to follow up the patient, and then you want to review whether this patient is actually a TRS or not, then you have to look for this 60 milligram haloperidol for 6 weeks. Then you have to give the haloperidol for 6 weeks and look whether the BPRS score reduces by 20% or not. If this is not the scenario, again the patient will be labeled as TRS. In modified Keynes, remember this is the only change that you have to read. Now, coming to TRIP, what is the time duration? What is the time duration? Symptoms time duration, it is more than equal to 12, more than equal to 12 weeks. Okay, more than equal to 12 weeks. Now, number of antipsychotic trial, come on. Number of antipsychotic trial, how many number of antipsychotic trial according to TRIP? Two or more than equal to two. Very good. What is the duration of these set of trials? What is the duration of these set of trials? Okay, very good. More than 6 weeks. 12 weeks is the symptom. Symptom duration is 12 weeks. This is the treatment duration, 6 weeks. What will be the number of treatment? Two. What will be the dose equivalent? 600 milligrams of chlorpromazine. 600 milligrams of chlorpromazine. Yes. And adherence, 80%. Adherence, 80%. One more important aspect, please focus on this part. Time course, early development of resistance, late development of resistance, and medium development of resistance has been given. So if I ask you medium development of resistance, it means what is the time frame that they are mentioning for development of resistance? If I'm asking medium development means after 1 to 5 years of treatment, I have landed up in a state where I'm having treatment resistance. So this is medium term onset. Medium term onset. LAI, the concept of LAI has been given in TRIP in optimum criteria. And what is the time duration if we consider LAI? What for how many long LAI should be given? Yes, 4 months. Now, according to the adherence part, according to the TRIP guidelines, in the adherence part, what are the changes in optimum? What are the changes in optimum? Yes, that is the serum level. Remember, serum level is included in optimum. It is always the serum level which is included in optimum. Okay, here at least you will be looking for adherence for at least two sources, and antipsychotic plasma level at least one occasion. Here there is serum level that you have to measure on at least two occasion. So serum level two occasion, one occasion in minimum, bare minimum, and here there is two occasion. This is where the difference lies. Okay, so without prior notification, that is there, that is common for both of them, but again remember the number 1 and 2, 1 and 2, 1 and 2. Okay, next. All of you have read this part. Done. Now, if I ask you to write about TRS according to APA guideline. Have you read about APA guideline in TRS? No. But still, even if you have not read it, you can write at least 4 to 5 things very common, which is being shared by all of them. Just mention it. Number of trials. What is the number of trials? Minimum of trial. 2. Treatment duration of how many weeks? 6 weeks. Yes. And remember that you have to give it at therapeutic range, and at least one should be second generation. Why I am including this? Because in all of these things, in all of these set of, it doesn't matter what is the guideline. It doesn't matter what is the guideline. Everywhere it is the same. Everywhere it is the same. Okay. Minimum duration is 6 weeks and 2 antipsychotic trial. This is what you have to know. Whatever be the guideline, it is just the same. I hope this part is clear. It's a kind of a hack which you can use even if you are writing about World Federation of Biological Psychiatry guideline, what write about the TRS criteria. Okay, give it to me. I don't have to worry. 2 antipsychotic trial giving with an optimum dose 6 to 8 weeks. You can have this. You have this flexibility. Okay. So is it clear to you? Is it clear to everyone? चलो चलो आगे बढ़ते हैं. Let's go ahead. And if you want to add something more to it, you can use this. Most of them, they are not specifying what is the chlorpromazine equivalent. Okay, but most commonly they mention about 6 weeks. 2 antipsychotic, different classes. Most of them, they don't mention whether it is different classes. So you can go with these common set of findings which have been mentioned over here, and you can write about any guideline. You can write about any guideline. These are the common things that you have to remember. If you remember this, most of your guidelines are done. But they'll not be asking about APA or something like that. They'll be mostly asking about the canes, modified canes, and drip. Okay, remember this. Know about this. Okay. Look into the data. Non-smoker, this is about the European population. 250, 350, 450, 550, and this is what you'll be reading for this Asian population. Now, coming to this, please do follow this clozapine man of yours. And right from head to toe, you can see that these are the list of side effects that you have to mention. Okay. One more thing regarding this side effect part, I'll just ask you one aspect. Now, the person can develop pneumonia with clozapine. What is the mechanism that leads to development of pneumonia? Yes, it is aspiration. It is aspiration. Why? Because see, person is sedated, decrease in cough reflex, leading to aspiration, which ultimately leads to pneumonia. So antipsychotic induced pneumonia can be there. It is not interstitial lung disease. Interstitial lung disease is another complication of lung. Coming to heart, what will be the problem in heart? What will be the problem in heart that can happen? Myocarditis, very good that you're mentioning myocarditis. Anything else that can happen? Anything else that can happen? Cardiomyopathy. How does cardiomyopathy? Yes, pericardial effusion doesn't allow the heart to expand, leading to cardiomyopathy, restrictive kind of a cardiomyopathy that can develop. The heart is not allowed to expand. Okay, remember this. Monitoring already you know. Now, this is the thing that you have to look for. Remember the new European Medical Agency guideline, actually, they have done a kind of a switch, and it is a good thing for all of you. Now, if you just remember this part, the US part, the same thing has been copied and pasted by the UK or the European Medical Agency. Okay, earlier we used to read that UK and US, there are different set of guidelines. Most of the people, they'll be following this because it's the recent update which came in last year, September. What was the recent update? The UK guidelines, which was a bit different from US. Now, US, same thing has been copy pasted by the UK part, and it is just like the US now. You don't have to do anything else. So it's a win-win situation for all of you. You don't have to mug up much. So weekly assessment till first 26 weeks, and then bi-weekly from 26 to 52, and then monthly. So if you know this, you'll be able to answer both the UK and the US guideline. Now, UK and US guideline, yes, quarterly they have given. So I'll upload a kind of a flow. I've already uploaded this. Else, what I'll do, I'll include this in the flashcard, and I'll upload this as a kind of a small booklet. All the flashcard combined in document section. So you can actually assess all of them. Okay. Chalo. Now augmentation. Chalo. Regarding augmentation, what are the modalities coming to antipsychotic? Recent IPS is just the same. According to recent IPS, I have also mentioned regarding there is an update portion in that. We'll come to that also. Don't worry. Yes, just let's focus on this. Let's focus on this. Let's focus on this, please. What is the modality of augmentation? Aripiprazole, amisulpride, haloperidol, ziprasidone, sulpiride. Mood stabilizer, valproate, topiramate, lamotrigine. No lithium. No lithium. Remember this. Okay. You can use this omega-3 fatty acid. Somatic therapy, all of you know. Case series shows pimavanserin plus clozapine to be beneficial. Now, if suppose a person is not able to tolerate clozapine, you do have alternatives to clozapine. Means these sort of antipsychotic will behave like clozapine if you give it at this dose. Okay, remember this part. Yes, high dose, high dose, high dose. Okay, already you know about these. Food, not important, but you have mentioned. Yes, next is smoking and clozapine. Remember, nicotine plays no role. It is not nicotine, it is rather the aryl hydrocarbons in cigarette which is associated with CYP1A2 inducing property, and hence it interferes with the metabolism of clozapine. Because if you smoke along with clozapine, you will induce your CYP1A2 enzyme, and there will be increase in the metabolism of clozapine. Hence, you need to give add-on clozapine to those set of patients who are actually smoking. Important part is when these patients get admitted in ward, you have to be very careful. How? Remember that now since they are in a smoke-free zone, there is no smoking going on, there might be a rampant increase in the level of clozapine. And then you have to adjust. Yes, it can lead to toxicity. Then you have to adjust the dose. You have to reduce the dose. How you'll be doing the reduction? So basically, you have to decrease by 10% every 48 hour. 10% every 48 hour. And what is the maximum reduction that is allowed? What is the maximum reduction that is allowed? 50%, half. So suppose I'm taking 400 milligrams. What is the, and I'm smoking, I'm a chain smoker, but when I'm getting admitted under you in a ward, what will be the maximum reduction that you can do? If I'm taking 400 mg, it will be 200 mg. Okay, it will be 200 mg. Very good. And yes, 40 mg reduction every 48 hour you can do. In my case, when I'm giving myself as a reference, as a patient, and if I'm taking 400 milligrams, every 48 hours you can reduce by 40 milligram, and remember that maximum you can reach is 200. And then you have to do plasma levels on day 7 and 14. Day 7 and 14. Caffeine also can do the induction part. Now this is an update that no more you need to look for the risk evaluation and mitigation strategy. Basically, it was hindering the use of clozapine in the patient who require it, as a result of which they have removed this, although they haven't removed the ANC monitoring. Okay, now coming to clozapine resistant schizophrenia. Clozapine resistant schizophrenia, remember the time frame is the same, 8 weeks. What is the serum level of clozapine that is required? More than equal to 350 micrograms per liter, and no improvement by 20% on BPRS scale. What is the list of symptoms that you'll be looking in BPRS scale? Two out of those four. What are those four? CUSH, CUSH. Very good. Now, if per se, according to TRIP, you will see here also 3 months, 80% adherence, doses like this, and less than 20% improvement on BPRS and less than 60% improvement on SOFAS. This is what is meant by clozapine resistance. Then you have to augment clozapine. And we have looked into the various modalities by which we can augment clozapine. Okay. Now, not only this, we have read about smoking and schizophrenia, and smoking and schizophrenia goes hand in hand. Remember, I'll be very quick on this. See, this part is your schizophrenia. Your schizophrenia, you'll see that patient with schizophrenia, there is increase in dopamine in striatal level, there is decrease in dopamine in cortex level, there is decrease in glutaminergic transmission leading to cognitive defects. GABA is also deranged and acetylcholine is also deranged. With tobacco, these set of findings get reversed. See, dopamine increases a bit in the cortex region. There is increase in glutamate activity because of alpha 7 receptors, decrease in GABA by acting upon alpha 4 beta 2 receptor, increase in acetylcholine. So basically, it is acting as a kind of an enhancer of certain set of neurotransmitter and it decreases only GABA. Yes, genetic basis is also there. We are not uh, denying that, but remember that you have shared genetic liability, which we will read in the coming section. Okay, but it is a self-medication kind of a thing which develops. So basically, patient who are having schizophrenia, they tend why they because by taking schizophrenia by taking cigarettes, by smoking cigarettes, what will happen? There will be improvement in the level of dopamine. Hence, they'll be able to perceive less anhedonia, less negative effect. By increasing glutamate and increasing acetylcholine, they'll be able to perceive improvement in cognition. And remember, decrease in GABA also leads to improvement in cognition. So basically, they feel that there is a kind of a relaxation which happens after taking cigarette. That is why they keep on smoking. And it's a kind of a thing that develops. Also remember that there is a kind of a shared liability because of the gene that is associated with smoking and that has been correctly mentioned as CHRNA. Even if you don't know the next part, it's okay. If you remember this, more than sufficient. More than sufficient. Okay. Now, these are the important factors that you have to remember regarding the positive and the negative prognostic factor. Positive factor, acute, female sex, living in developed nation. Again, you have to take it with a pinch of salt that according to synopsis, they mention it as developed nation. According to IPSS and DOSMED, they mention it that the benefits were there more in those set of patients who were living in which country? Developing or developed? So it was developing country. So remember this, there is a kind of a mismatch. Okay. In that scenario, it is better to avoid this part. You can avoid this part. If it is too much contradictory or too much controversial, we can omit this. You can write about these things. Okay. Now, code guidelines, all of you know code guidelines. I'm not going in detail. Remember, act for society. Look for the society. Assertive community treatment, CBT for psychosis, token economy for doing reinforcement, family based intervention. You have to look for illness evaluation, crisis intervention, emotional support, coping skills. I'll just ask you in which stage, acute, maintenance, or continuous, will provide psychoeducation and family based intervention? Where are you going to provide for management of schizophrenia? Very good answer. All. Be it in acute phase, maintenance phase, continuation phase, in all these set of things, you have to look and provide for psychoeducation. And psychoeducation, don't at all forget to mention when you're mentioning the management of schizophrenia. Skills training, these will include behavioral based intervention, rehearsal, role modeling, positive reinforcement, and corrective feedback. Then you have supportive employment and control of addiction and substance use disorder and weight management. Pseudo community can come as a short note. Next, CBT for psychosis. Remember two of the models. What are the two models of CBT in psychosis? One starts with M. Yes, one is Garrett and yes, very good. Morrison's model is there. All of you look into your notes and try to answer what are the two models associated with CBT in psychosis. Morrison and Garrity. Morrison and Garrity. Remember this part, please. What is the total number of sessions that is given as per NICE? What is the total number of sessions that you'll be going for CBT in psychosis? Look into your notes. See, 16 sessions according to NICE guideline. 16 sessions. And remember that the treatment outline is like this. You have to do a collaborative assessment, formulation of problem list, setting out your goals. Then you have to focus in cognitive part, alternative explanation, counter the patient. Then you have to provide with evidence that, okay, the hearing part or the hallucinations which you are hearing is a part of your disorder, not the distorted reality in which you are able to perceive. Then you have to look for imagery. You have to provide attribution and correct it, activity scheduling, and behavioral experiences. And with this, you will complete your CBT for psychosis. Please, please, please do go for these set of diagrams that we have mentioned in model, that is Morrison, and this is Garrity. Okay. Now, next, catatonia. Name all the scales which are there in catatonia. All the scales that is going to help us to assess the patient. BFCRS, very good. Canner, next. BFC, drawing, Roger, modified Roger, Northoff. This much scale you need to know if you are writing an answer in which you have to mention about catatonia. BFCRS, Rogers, modified Rogers, Kanner, Northoff, Browning scale. Okay, now if you look into this, this is the two kind of thing or the extreme that is present with catatonia: hypoactivity, hyperactivity. Okay. Now I have already mentioned regarding the neurobiology. I'll be just asking you in which set of psychiatric disorder it is more common, mood disorder or schizophrenia. So it is more commonly associated with mood disorder. Okay. Now if I ask you, what is this? These are the basic set of things that you have to remember. Next, I'll be just looking into the management part. I'll be just going into the management part. Okay, in the management part, how do you do the lorazepam challenge test? How do you do the lorazepam challenge test? Come on. 2 mg IV. According to Bush Francis, you have to give 2 mg IV. Okay, very good. Loaded in a butterfly, and 1 mg to be given. Observe for 5 minutes. If there is any decline in score in a standard scale, it is considered to be LCT positive. If there is no response even after you have given for 1 mg and you have done the assessment and you have looked for the patient till 5 minutes, after 5 minutes you will be giving the next 1 mg and you have to observe. If there is a decline in score, LCT positive. If there is no, LCT negative. What was the update that came? That in Bush Francis, or sorry, in this Fink and Taylor, we are not saying that there should be a reduction by 50%. Yes. In Fink and Taylor, we are not saying that there has to be a reduction by 50%. But according to the guideline which came in 2023, 50% reduction in a standardized scale is mentioned. So accordingly, frame your answers. According to Fink and Taylor, there is only a reduction that is required in a standardized scale. According to BAP guidelines, which came in 2023, 50% reduction is required in a standardized scale. Coming to Zolpidem challenge test, 10 mg oral, and remember, this is the level that you have to assess. It's not possible just to give Zolpidem and there will be reduction. No, you have to do a serum level also. And remember, onset of action is 10 to 30 minutes after ingestion. Coming to the management part, what are the steps that you are going to give, or how do you manage a patient who is having catatonia? Yes, the first step is IV lorazepam. IV lorazepam, what is the dose? What is the dose of IV lorazepam? You'll start with 2 mg. You'll start with 2 mg and you'll maintain at 6 to 8 milligrams, and you'll be giving it. Very good. Divided doses. What is, yes, 6 to 8 hours. That is the time frame that you'll be repeating it. So basically, you are giving 4 times a day. QID. Okay. And then you'll prepare the patient. You'll prepare the patient for ECT side by side. Very good. Now, if you have planned that, okay, if I'm a patient coming to you, you have given me lorazepam, there was some improvement, but again, there was returning of catatonic symptoms. Then you have planned for ECT. Suppose I have been planned for ECT under you. What will be the minimum number of sessions that you'll be giving? 6 sessions minimum. But remember that 2 to 3 sessions is difficult to is sufficient to lyse catatonia, but 10 to 20 sessions might be needed. On an average, you require 6. Next is glutamate. So you can remember it as GAP, glutamate, anti-epileptic, then psychotic symptoms, GAP. So first amantadine, memantine has to be given. If the person is not able to tolerate or person there is no improvement, you can go to anti-epileptic drugs like valproate and carbamazepine. Again, here there is no lithium or lamotrigine in this. Remember, it is only valproate and carbamazepine. And then you have step 5, that is aripiprazole, olanzapine, and clozapine. Now, coming to Maudsley, Maudsley says pretty much same. The only thing is they say that if you have ruled out NMS and the patient is not taking any antipsychotic medication, you can consider using SGA. And these are the SGA that has been mentioned along with benzodiazepine. And no response in 24 to 48 hour, you can follow the ECT protocol. Okay, so the same thing goes over here. This is the time duration that they are mentioning, 48 hours. And this was also mentioned in the previous article by Beach. Very classic article as far as catatonia management is mentioned. Here also you have to look for this 24 to 48 hours. Don't wait more than 24 to 48 hours. And write this whenever you're writing the flowchart or the treatment protocol for catatonia. 48 hours, 24 to 48 hours, and then you'll go to ECT. Okay, now periodic catatonia, remember it lasts for 4 to 10 days and there is a switch which happens. Okay, hyperkinetic catatonia, hypokinetic catatonia, and they keep on moving from one phase to another. Acute management will be same like that of catatonia. Maintenance prophylactic lithium can be used. Coming to ATPD, okay, ATPD, what is the most common cause of ATPD according to CAPS study? Fever, and non-organic part was returning back to maternal home. Okay, that was the part. Coming to, okay, this is the transfer that has happened. Acute polymorphic disorder without schizophrenic symptoms. This is the real ATPD in ICD 11. And the rest has been transferred under different set of rubric. Okay, so this is done. Acute part, you will be doing it. Remember about this. Remember about this differential diagnosis and what it might suggest. Coming to physical examination and blood test, all of this part you are already knowing it. Now, coming to psychodynamic theory. Psychodynamic theory, remember family theory, family from, okay, so schizophrenic mother. Mother is cold, mother is not showing affection, the person can develop psychosis. Means the mother is cold, rejecting, and controlling. If this is the set of features in a mother, she is considered to be a schizophrenic mom. And this was given by From Richmond. This is family theory. Double blind, you have Bateman and Jackson, conflicting and confusing command that can lead to object relation theory, Freud theory have all been mentioned in psychology part that we have dealt in detail over there. You just go and read, you'll be able to connect the dots. But that has been mentioned over there in detail. We have written over a page what is meant by object theory, Freud part is also there. So you please go back and just have a look. You'll be able to connect the dots, no issues. And remember this, even if you mention these these five, it is sufficient. But do add object relations theory. Okay, fine. Maternal skew and schism. So SST, this is division of family in two antagonistic and competing groups. Communication and deviance. Okay, this is by Singer, that amorous pattern of or fragmented thinking. Pseudo hostility by Lyman. Absence of true intimate relationships. Okay, now coming to delusional disorder, again look into the prevalence. Overall, female more than male, paranoid more common in male. Okay, I have not written anything. Hari Krishna, I haven't written anything. Basically, these are the annotated notes that I have asked you to bring. I haven't written anything new. Okay, so if you want, there is no purpose of going through these set of notes. You have your own annotated notes, you can download it now. Same thing is there. Nothing, I'm not mentioning anything new. Just be focused, just attend the class with full focus. You'll be able to recall a lot. Okay. Don't be in a hurry. You don't have to look for these set of notes. These are all, these are all haphazard kind of writing over these notes. Good notes are there in annotated segment. Okay. Chalo. Now, remember what is the time duration for delusional disorder? What is the time duration for delusional disorder? 1 month, 1 month, one or more than 1 month. Very good. Now, important part is this. These are the type of delusional content: persecutory, somatic, jealous, grandiose, erotomanic, mixed type, unspecified. Okay. JPEG image, JPEG, and these are the types of delusional content. Now, remember, this is the treatment approach. Firstly, you have to ensure there is safety for patient, that the patient safety is of utmost important, because if there is a persecutory kind of a delusional disorder, the theme is like persecutory, you have to ensure safety. Therapeutic alliance, enhancing self-esteem and improving skills, and targeting emotion and behavior. Okay, you can use therapy and treatment. Per se, there is no good outcome either by using antidepressant or antipsychotics. The only thing is comorbid depression or anxiety that, if at all present, is being taken care by antidepressant. Antipsychotic per se is not showing any kind of benefits. Now, what are the findings according to the same article? It follows a very stable course, means it is a continuous kind of illness where there will be exacerbations followed by remissions, again exacerbation followed by remission. And remember that response is very poor to medication. 60% full mild residual recovery over 30 years. Other studies suggest relative stability. So basically, there will be incomplete remission, there will be partial remission, again there will be exacerbation. So these set of patients, outcome is poor. Remember that when you compare it with schizophrenia or schizoaffective disorder, DD generally shows better global function. Males may have poorer function and more severe symptoms than female. Okay, remember this part. Now, course and outcome of schizophrenia. Remember, for those set of people, if you look into symptom wise domain, right from the premorbid period, you will see that cognitive deficits, which are mentioned in this blue line, it is already present right in the beginning. But in the prodrome, you will see negative symptoms develop. Remember, prodrome is very much significant, specifically in congenital schizophrenia or those set of people where development of schizophrenia or these set of symptoms, it happens early in their age. Predominantly negative symptoms, and then once you cross the prodrome or during the prodrome also, you have this positive symptoms, but there is progression of negative symptoms, positive symptoms as the disorder progresses. So remember one more aspect, that positive symptoms fluctuates, negative symptoms and cognitive symptoms are stable, and symptoms increases with age and course of illness. See, it keeps on fluctuating. Cognitive deficits is very static and it keeps on increasing. Negative symptoms also increases with age. Okay. Now, so whatever you have read, this is a kind of an overview or an integration form in which you can see that when a person takes birth, right before that, because of the family part, there is genetic loading. There is genetic loading. Okay. How? Because of the genetic mutation which is already present in father and mother. Then there can be some of the environmental factors which can actually hit the patient right in the beginning. Okay. Yes, we do need to complete the course and progress. Yes, I have provided the course and outcome as a separate booklet. You can go through that, specifically the initial parts. Specifically the initial part. Okay, not the current evidence. Not the current evidence. You can go with the initial part. See, trauma and infection, winter, hypoxia, or malnutrition. If this is present right in the beginning, this is the first wave that has hit the child. Now, if these are the second triggers, if that can happen in 10 to 15 years of age, well, you'll see that there is functional impairment which is happening, but frank psychosis per se has not developed during this part. In 20 to 25 years of age, this is where you get a diagnosis of schizophrenia, and you'll see that the symptom severity, it keeps on fluctuating. And whenever there is a crisis or a relapse, it will come and go. what is happening during these phases, this is being mentioned over here. What is happening during these phases has been mentioned over here. Okay, so you can make a kind of a comparison. This per se is important. Yeah, this is important. Lieberman has defined premorbid, prodromal, symptomatic, residual. If a person is coming in premorbid form, there is no frank psychosis. There will be certain social, motor, cognitive decline. You can find neuronal soft signs. You can find minor physical anomalies during these set of things also. Okay, endophenotypes will be present. In prodrome, functional decline, attenuated psychotic symptoms, negative symptoms will be predominant, associated with anxiety and depression. And remember that you need to provide needs based care, CBT for psychotherapy, for psychosis, and low dose antipsychotic if at all required. First episode psychosis, you need to go with the treatment that we have already discussed. And chronic phase is associated with stabilization of residual or negative or cognitive symptoms. Remember this. And we come to the end of psychosis. Okay, so if you have gone through all of these important points that we have discussed in psychosis, it will be really easy for you to revise it. It will be really easy for you to revise it. Go through these important points that we have mentioned today. And whenever you are revising it, try to make a habit of using sticky notes, or per se, you can write it in form of a notebook also. Some of the important data that you have to look for, like for example, epidemiological data, and you can mention regarding the data for the diagnosis, like 2 out of 5 is required, or 2 out of 7 is required in ICD-11. Okay, this is according to DSM-5. So you can make this kind of a small sticky note, so that these important data doesn't go out of your sight whenever you are revising it, or in the last day. This will be something as a savior. This will be helpful for you to keep all the track of important data. Also, you can make a list of genes. If at all it is difficult for you, try to make a list of genes and stick it. Next, you can remember, okay, in data also you can mention regarding the duration of treatment. One more thing that you can make a note is on the components of port guidelines. Nothing else. And you'll be able to cover psychosis pretty much easily.